Hi everyone, I'm Sunil Rege, consultant psychiatrist. If you're new to this channel, don't forget to subscribe if you're interested in all things psychiatry and mental health related. Today I'll be taking you through a fascinating topic on psychedelics in psychiatry. Now, many of you would know that there has been a lot of discussion, a lot of excitement about the use of psychedelics in psychiatry. So let's jump into it and check out what are psychedelics in psychiatry and what is the evidence to date. Now, psychedelics in psychiatry is not a new phenomenon. In fact, during the 1950s, somewhere around there was quite a lot of excitement about psychedelics. And many people remember vaguely that LSD and other psychedelic drugs were once used experimentally in psychiatry, but few realize how much and how long they were used. This was not a quickly rejected and forgotten fad. Between 1950 and the mid-1960s, there were more than 1,000 clinical papers discussing 40,000 patients, several dozen books, and 6 international conferences on psychedelic drug therapy. It aroused the interest of many psychiatrists who were in no sense cultural rebels or especially radical in their attitudes. The use of LSD and marijuana by so-called hippies who demonstrated against the Vietnam War during the 1960s created great consternation among authorities and legislative bodies, both at the federal and state levels. Anti-war attitudes and rejection of conventional social norms by adolescents and college students were often perceived by the mainstream culture to be a consequence of drug use. Hence, these substances were often believed to be perverting the minds of our youth. Furthermore, the outspoken Harvard University professor and firebrand Timothy Leary encouraged young people to turn on, tune in, and drop out, essentially coaching them to take drugs, discover their true selves, and abandon convention. Such messages did not play well with the mainstream culture, all while the mass media fanned the flames of public hysteria with greatly exaggerated reports of drug-induced insanity, chromosomal damage, attempts to fly, and so forth. And that's when it sort of started falling out of favor until more recently. So what are psychedelics? Psychedelics, also known as hallucinogens, are a class of psychoactive substances. Psychedelics are any of the so-called mind-expanding drugs that are able to induce states of altered perception and thoughts, frequently with a heightened awareness of sensory input, but with diminished control over what is being experienced. So that's the definition of psychedelics. Now, in some cases, when we look at psychedelic substances, hallucinogens, ketamine is added in and MDMA is also added in. They're hallucinogens in a way, but not necessarily psychedelics. What are the common types of psychedelics? Psilocybin is well known. Magic mushrooms, lay term, is found in several types of mushrooms and when ingested is metabolized to the serotonergic receptor agonist, psilocin. So we'll look at the specific mechanisms as well. Then we have LSD, is made from a substance found in ergot, which is a fungus that infects rye. Then we have mescaline. Mescaline is derived from Lophophora williamsi, a small cactus native to northern Mexico and the southwestern United States, as well as San Pedro cactus. It produces similar effects to LSD and was also the first naturally occurring psychedelic alkaloid to be isolated in the lab. If you're looking to learn more about this topic and discover a range of other stimulating psychiatry courses, then don't forget to subscribe to the Academy by PsychScene. Then we have DMT. Dimethyltryptamine is structurally similar to psilocin, an alkaloid found in psilocybin, which we just touched on. It can be synthesized in lab, but is also naturally occurring component of several plants. Then we have ayahuasca, which we know is a Quechua term for vine of the soul, so quite popular in South America, and was first described in the 19th century by botanist Richard Spruce after an expedition to the Amazon. It is thought to contain more than 90 different plant species from 38 plant families. And then we have MDMA, which I talked about. Whether it comes under hallucinogens or psychedelics, sort of debatable. It possesses properties of both methamphetamine, and that's the reason, because it's got this methamphetamine type property, but it also has this mescaline. So technically, yes, maybe you could put it in here. What are the applications of psychedelics in psychiatry? Now, although there are a number of studies and ongoing research on the applications of psychedelics, and it's a rapidly changing field. So what I might have covered here might change within a few months even. So new data keeps coming up and keep updating that. So firstly, let's look at psilocybin. and the mechanism of action. We've got the 5-HT2A receptor that it acts on, the 5-HT1A, and note that these are the same receptors that antidepressants also act on. And we have 5-HT2C. So psilocybin is dephosphorylated by hepatic first-pass metabolism into the 5-HT2A1A and 2C receptor agonist psilocin. And we have trials, of course, of psilocybin, which I'll talk about. So very similar receptor profile to SSRIs, because SSRIs also tend to activate these particular receptors. Then we have LSD. Now LSD, again, similarly, you've got the 5-HT2A receptor and 5-HT1A alpha 2 adrenergic, and you have the dopamine D2 receptor as well. Now the 5-HT2A partial agonism is what is associated with those hallucinogenic effects. And it's a 5-HT1A partial agonist, which technically may provide anti-anxiety effects, antidepressant effects as well. Then we have DMT and methyl ditryptamine. Now this is interesting because it does have the 5-HT2A and 5-HT1A as the others, but it has this TAR. And TAR is the trace amine associated receptor, and it's a mediator of consciousness and perception. Interestingly, the TAR receptor is becoming a mode of action in medications such as clozapine for psychosis, MAO inhibitors for depression. So you can see the overlap. Similarly, you have sigma-1 agonism. Now, fluvoxamine, which is an SSRI, is a sigma-1 agonist as well. And that's why fluvoxamine and COVID-19, due to its immunomodulatory properties, showed benefits in reducing hospitalization rates, the severity of COVID. So it's really fascinating. We think about agents, the brain, the body, the immune system is connected. So we have antidepressants that also have immunomodulatory properties, something we've covered in the mechanisms of antidepressants as well. And you can see 5-HT2 agonism leads to hallucinogenic properties. Then ayahuasca. So when we think about ayahuasca, it has DMT, so just like what we covered, the major alkaloid present in the leaves of Psychotria viridis, which is a hallucinogen. And then it's also got these beta-carbolin alkaloids, harmine, tetrahydroharmine, and harmaline. Now, these have effects very similar. It's a MAO inhibitor, which is a monoamine oxidase inhibitor. It's the enzyme that breaks down serotonin, noradrenaline, dopamine, MAO A, MAO B. And it also contains trace alkaloids in the bark and stems of the vine Banisteriopsis caapi. So you can see it's got multiple effects. It's got the DMT, the hallucinogenic effect, but it's also got an antidepressant effect as well. So here you can see DMT is rapidly metabolized by the MAO in the gut following oral administration. And you've got beta-carbolin alkaloids are potent MAO inhibitors. So it has an exaggerated effect as well. So let's look at the studies. Psilocybin. Now there have been proof of principle studies as a phase 2 study as well, which right at the end I'll talk about. But the proof of principle studies in healthy individuals showed that psilocybin assisted psychotherapy elicited long-lasting positive changes to behavior, attitudes, and personality. Volunteers in these experiments also reported that while under the influence of psilocybin, there were challenging and frightening experiences to overcome. However, these were manageable and resolvable with interpersonal support. Now, I have done an interview on this channel that you can view with Professor David Nutt. He is a leading expert and is carrying out a number of trials on hallucinogens. Do have a listen to that one. Now, pilot studies have suggested that when used in conjunction with CBT, psilocybin may be useful for smoking cessation and treating alcoholism. So similarly, LSD during the early years, 1950s, 1960s, actually showed significant benefits, and we'll see that in treating alcohol use disorders. More recently, research into psilocybin's efficacy in treatment-resistant depression revealed that 10 to 25 milligrams significantly reduced quick inventory of depressive symptom scores and resulted in the complete remission in 67% of patients as measured by the Beck Depression Inventory. Note that these are smaller sample sizes though. And the phase 2 trial, this one most recent, led by Carhart Harris, another leading researcher, did not show a significant difference in antidepressant effects between psilocybin and escitalopram in a selected group of patients. Small numbers though. And interestingly, there were some secondary benefits for psilocybin. Now note that in all of these, combined with psychotherapy as well, supervised psychotherapy. The mechanism is being postulated something called rebus, R-E-B-U-S, which is relaxed beliefs under hallucinogens. The rebus phenomenon is basically, just as it says, relaxed beliefs, which means that there is a certain amount of free flow of thoughts, etc., that can benefit the patient, can help in processing of depression, trauma-related disorders, etc. Now, LSD. LSD has been repeatedly shown to be an effective therapy for the treatment of alcoholism, even after a single dose. A meta-analysis of 6 double-blind placebo-controlled trials showed that alcohol misuse was significantly reduced in 59% of patients after a single LSD dose of less than 50 micrograms. LSD has also been successfully used in conjunction with psychotherapy to treat anxiety linked to a life-threatening disease such as cancer. A 12-month follow-up of this investigation showed that effects of LSD were sustainable, with 66.7% of patients reporting an increase in quality of life and 77.8% reporting reduced anxiety. So of course these numbers, really, really promising. But the question is whether it can be applied as a whole to the population with those disease states. Mescaline, very much in the observational stages. Studies in Native Americans shows the potential of mescaline in alcohol addiction. DMT has been implicated as a mediator of consciousness and perception because of the TAR1 receptor, but there are no clinical studies as of yet. Ayahuasca may have a potential in addiction and depression, but more methodologically robust studies are needed. MDMA has been shown to facilitate the release of oxytocin, the hormone associated with early infantile bonding, and that's why MDMA is showing some promise in post-traumatic stress disorder. It can enhance social bonding significantly as well, and may increase levels of empathy, closeness, and damper fear-related amygdala activity. That's where the benefits in PTSD may come in, causing a decrease in stress response and social anxiety as well. So again, MDMA showing some promise. So key points really, as I said, this is something that will change quite rapidly. So first, let's look at the TJ approval for psilocybin and MDMA for very specific indications. Psilocybin for treatment-resistant depression and MDMA for PTSD. This is big news. Evidence from recent studies has shown that psilocybin and MDMA may yield therapeutic benefits in such patients, providing they're prescribed in very controlled clinical settings. What the TGA has said is from the 1st of July 2023, psychiatrists will be given specialist authorization under the Therapeutic Goods Administration to prescribe psilocybin for treatment-resistant depression and to use MDMA in the treatment of post-traumatic stress disorder. Essentially what this means is that the TGA has reclassified psilocybin and MDMA as medications. Both these medications will be listed as Schedule 8, which is controlled drugs in the poison standard for these specific uses that I mentioned, and of course Schedule 9 if used outside these settings, because Schedule 9 means that these are prohibited substances. Now, we're not quite sure how this will be implemented in the real world. So we know that authorized prescribers will require an application to the Human Research Ethics Committee. Now, the other challenge is that products containing psilocybin or MDMA, we're not quite sure where these are going to be sourced from, and they haven't been evaluated for their quality, safety, or efficacy in terms of these specific formulations. We know there are so many companies around the world now with this news, of course, making a big dash towards the production of these specific formulations. When we take a step back, great news for psychiatry in terms of advances. We're looking outside the box. And we can't forget last year there was a program that showed some serious concerns around these particular therapies.
That happen in psychedelic therapy is being complicit.
How much else has been covered up and how much else is out there?
Four Corners
Therapy. So this is something to wait and watch. Nonetheless, an exciting time to be in psychiatry. So further research is required to assess the safety, efficacy, and effectiveness. Effectiveness is what happens in the general population. And as we know, we need to go through stages, phase 1, phase 2, phase 3, and of course, post-marketing, what happens as well, if it does get there, to inform future potential use in psychiatric practice. So I hope that you found this video on psychedelics useful and enjoyable. If you liked it, leave us a like. Thank you so much for watching and supporting this channel. I really do appreciate it. Look forward to seeing you in another edition of Hub Bites. Until then, take care and stay safe. Bye-bye. Synthesizing complex material in psychiatry to simplify your practice.